With the abstract we had this year at ASH, we were really focused on how is the best method for determining whether or not patients with aggressive lymphoma actually achieve remission. So all these patients get treated with the goal of cure, and you have to first achieve remission before you can be cured. So the way we do it currently is reliant almost exclusively on imaging scans, but we know they have certain limitations, like when they remain positive after therapy, oftentimes the patients don't have lymphoma, and other times when they look like the patient has achieved remission, about 15% of the time those patients actually relapse. So what we were interested in was comparing the predictive ability of, in this case, PhasED-Seq to PET scans at the end of therapy to see if this was a more predictive way of determining whether a patient was truly in remission or not. So we were interested in studying this in the context of a prospective clinical trial. So these were patients who were all enrolled onto a trial we had at NCI. They're all treated with curative intent chemotherapy. So we prospectively collected plasma at key time points, such as the beginning of therapy, after 2 cycles, and at the end of therapy. And we were interested in determining what was the predictive value of standard response criteria versus something emerging or new, such as circulating tumor DNA. So the most important thing about this analysis that's different than other analyses we've done is we had the PET scans read in a blinded way by nuclear medicine doctors, and we had the plasma samples analyzed by PhasED-Seq also in a blinded way, so no one knew the clinical outcomes, and then we were better off to be able to compare these different modalities. So we know that when patients are treated with chemotherapy, that the majority of them will be cured and they'll achieve remission. In our study, we saw about 85% of the patients actually achieved long-term remissions. What we were interested in is determining if we could predict patients that may not achieve long-term remissions as early as 2 cycles. So we saw after 2 cycles, if we looked at PhasED-Seq in the patients that were undetectable, which was almost 3/4 of the patients, almost none of those patients relapsed, whereas patients that still had some residual circulating tumor DNA had a much inferior prognosis. The second thing we did is we looked at the end of therapy. So this is when we've completed all planned therapy, and we needed to know if the patient was truly in remission. What we saw was that the standard analysis, which is a PET scan, that was predictive of patients that were in remission, but it was not nearly as predictive as the end of therapy plasma sample analyzed by PhasED-Seq. And the important thing there is that when patients tested negative at the end of therapy, we didn't have any patient who actually progressed after therapy, and that wasn't the case with PET scans. Well, I think the first takeaway, which has been known for a while, is that clinicians should not be acting on single PET scans. It's too often that those have a positive result, but the patient doesn't have active lymphoma. So I don't think we should be taking patients to second-line therapy and determining them not to have achieved remission just on a single test. There's additional tests that are required to actually know whether the patient's in remission. I think that's point number one. The second thing is this is adding to a body of literature that is highly suggestive that these blood tests, these non-invasive tests, actually hold more predictive value than these imaging tests, which makes sense because they can detect disease at such a much lower level than you can detect with imaging scans. So I think what we'll see is as this body of literature gets larger, perhaps it's an opportunity to improve the way we define remission. Maybe we will enhance our response criteria. And ultimately, this might be the best way for us to determine who no longer needs additional therapy in this cohort of patients with aggressive lymphoma.